Okay, we'll wait until the tape gets started, but there's your warning bell. Okay, let's do that again. Okay, we just have to make sure the recording system is going. It is not yet, so this is in the theater profession. This would be places. Oh, in the middle. Oh. Okay, the tape is rolling.
Yes. Did you get a phone? I did not.
We are back from recess and continuing with our hearing on government program and HMO transparency and rate setting. And so once again, I'll thank our testifiers for being here and any of the helplines that they may be calling in. I have been asked to mention, and this was not by anybody from partisan staff or anything like that, but in fact from the facilities people, the sergeant, I think, that we, at least with the previous hearing, we were almost at room capacity. So there was a request to have people, it's kind of like church. Everybody sits in back and the front pews are open. So the front pews are open. Please move to the front so that there's room for people in back. And then if we start getting full again, we have overflow seating, and I believe there's televised and audio. So if you want to observe this, you can do that in room 181 of this building, so one floor down from here. So again, move forward, allow room for people to sit in here, and then as we fill up, there's overflow seating and video in room 181. I'm Representative Steve Gavel, Chair of the Health and Human Services Reform Committee, and so this joint hearing now continues. And what we're going to do is continue with questions from committee members as they return.
Mr. Chair.
And just a moment, Representative Gruenhagen. We will try to go back and forth between Republican and DFL questions just to kind of underscore the nonpartisan, bipartisan nature of this hearing on transparency. So with that, Representative McDonald was next, and I see him returning to his seat. So Representative McDonald, you're up. In the meantime, Representative Gruenhagen, did you have a question? Or?
No, I was just going to say if the Representative McDonald wasn't here, then I was willing to take his place and ask my question.
Okay. Well, he is. Representative McDonald.
Gruenhagen would like to jump ahead of me and I could be next. That'd be great because I'll collect my thoughts after that break.
Well, we actually have a list. Representative Gruenhagen has had history, and we'll go back. If we get through the list, we'll go back. So I'm not trying to play favorites here at all. If you're not ready, we can go to the next in the list and come back to you. Representative Quam?
Thank you, Mr. Chair. During the testimony, I heard a desire not to report the same information to and then 3 departments listed. I can understand that. I hope we're reporting the same data, and I'm wondering if utilization of some of the newer analytical tools to be able to make sure that you write a query and you just update those queries might be the route to go, and that makes it easier for when you're doing audits. And I've had people come to me who are familiar with the auditing of, say, pharmacists and dentists, and their auditors have tools that run through the data, pick out, they want examples of this type. They'll go through and pick out random, but also picks out anything that's flagged as abnormal. And I'm thinking that there's a huge amount of data that the departments ought to look for, some of these analytics tools in order to better leverage the time in auditing so that you can actually go down to the details. If you have to pick up the papers and look at, and that way at least you have a continuum of the oversight and then avenues of details, and we don't let something skip and miss, because a lot of businesses have saved a great deal of money by using these tools and time. But I am concerned that providers seem to maybe be taking the hit when the plans are sort of guaranteed up to a certain amount of administrative overhead, and profit. I would think that if you added, I wrote down 100K, but you said over 100K increased participants, that if you've got the same overhead, that you would be more efficient. And be nice to see a trending of improved efficiency, and I was wondering if any of that data is available, because, you know, frankly, if I increase 10 or 20% and I'm doing a business, I don't, you know, I've got some efficiencies and I don't have to charge my customers as much. So can you talk about how you look at those efficiencies and hopefully drive down the administrative costs?
I think maybe that's a question for both Commissioner Jessen and perhaps Mr. Lights. Commissioner Jessen?
Mr. Chair, Representative Kwong, thank you for that question. At DHS, I think that we will be perhaps the heaviest users of these new data analytic master contracts, you know, because those are some of the very things we're looking at. How can we use the data analytics tools to look at, to help us do that first cut, to say, okay, where should we focus where are the red flags? Where should we focus our attention? And so I agree. We should do that. Though I also think that there's a point to, if you're having to file basically the same report with 3 different agencies, you know, there is some duplication there that I think the MNB's task force really should look at. Because it's not only do you have the plans doing it 3 times, you also have 3 different state agency folks doing it. So I think that that's a legitimate concern. And on the lower administrative costs, I mean, that's something that I think we will look at again with this new data that we're getting as a result of last year's legislation, where we get more of the administrative data. But I would say that in the budget that was passed, it was in the governor's budget passed by the legislature, I think it was very much a bipartisan effort last year, we lowered the maximum amount that health plans can charge for administrative costs. And we lowered that to where I think it's the lowest in the nation. And part of that, at least in our thinking, was we do have more people. There should be some efficiencies. But we'll certainly look at that again.
Okay, Representative Quam, any follow-up? Okay. We'll go to Representative Hosh. And just again, for members who came back, we're going to continue with the going back and forth between DFL and Republican to kind of underscore the nonpartisan, bipartisan nature of the hearing. Representative Hosh.
Thank you, Mr. Chair. And, you know, this definitely shouldn't be a partisan issue. And it's, you know, sometimes I have to kind of reconcile some, you know, some of the inconsistencies that we all face as elected members, because, and this was one issue that I think does that, when it comes to how do we contract out essentially government services to a pseudo private entity, and then what is an appropriate level of oversight, of management, of regulation. And with a lot of the concerns that are placed today, you know, we shouldn't be frustrated with the players involved because of a lack of understanding or clarity. We should almost be frustrated with ourselves, because we've been asking these questions quite a bit. I hope that we have more than just legislative hearings on this issue, but actually start talking about ideas. What direction do we want to go? I think there's a lot of potential bipartisan agreement in that area. And also try to reconcile what we've done in the past. I mean, just as recently as the last legislative session, not only did we try to clamp down on, you know, some of the HMO concerns that we have, but we expanded the use of our contracting with HMOs when we allowed for the enrollment into special needs basic care for the disability population in HMOs. That's not a bad thing, but we still have to be able to answer questions. Also, you know, when we just talk numbers, I want to caution using numbers saying, oh, well, you know, our PMAP payments have gone up this percentage over a number of years, because in healthcare, it's always more complicated than what is met at face value. We have to consider utilization, we have to consider enrollment growth, and we have to consider medical inflation, which is significantly different than just inflation. And these are all things that we should be asking and talking about. And, you know, this theoretical black box, how big is it? And we don't know that. I hope now that there's next steps beyond today. You know, we've got a packed room right now for the hearings. We had TV cameras. I'm assuming the room won't be quite so packed if we start talking the details and the nitty-gritty of things. It's not as attractive of a political issue, but it's something that we've got to be doing. And we spend $3 billion a year when it comes to public enrollees in health care. We have gone down a system in which, like it or not, we have taken government services and we have contracted them out. And I don't think we have enough regulation and oversight of that. There's ideas on the table. I hope we consider them regardless of who is the author of the bills, if it's Republican or Democrat. And I hope you do that, Mr. Chair. That's just what I wanted to say, and I'm glad to hear kind of the direction that the questions have gone with today, because this hasn't been finger pointing. If anything, we should point the finger back at us and say it's time for us to act.
Representative Hosh, I appreciate those comments, and just a bit in response to your request. I think that's exactly right. Our committees are charged with doing our legislative responsibility, and I know there is legislation already jacketed. There's legislation, I believe, legislators on both sides of the aisle who have ideas for improved transparency in government programs in the Health and Human Services area. And I know Commissioner Jessen and I have talked about some of this, Mr. Leitz and others. And so I think we will see substance coming forward this session. In fact, that would be my hope coming away from this hearing. It's one thing to kind of do some fact-finding, but then it's our responsibility to do something about it. I would agree. Thank you. Representative McDonald, are you ready?
Thank you, Mr. Chairman. Yes, I'm ready.
Right.
I'd like to address one of Mr. Feinwach's emails that he showed us as testimony, in which it said, Commissioner Jessen said that there's a good chance of keeping all this money. It must be characterized as a donation. If it's a refund, then the feds clearly get half. So the question is this, Commissioner Jessen, you said earlier in your testimony that you believed it was a refund. And if that's the case, since when is a refund considered a donation, or since when is a donation considered a refund when it's paid by the Minnesota taxpayers? So I wondered if you could clarify the statement that that it must be characterized as a donation, and if it's not, then it should be half should be paid back by the to the feds. And then also, is Karen Peed here?
I don't believe she is. I don't believe she is, no.
So perhaps someone could answer why she said that if you can't keep a secret, you must leave the room. What is the secret? Is that the $30 million? And that's my question.
Okay. Commissioner Jessen?
Mr. Chair, Representative McDonald, I think perhaps you misheard my testimony, or it's possible I misspoke, but I said that I very much thought this was a donation, that they appeared, I didn't ask for this money, they appeared in my office, UCare did, and told me about the donation. When I saw the, I think the email, and this was just it was a data practice request, they asked for all my emails related to this, and I turned them over. It was when I was looking at a draft press release, and I was trying to clarify that we should characterize this in our press release as a donation. So from a kind of federal relations perspective, if it's a donation, then we have a reasonable argument that as a donation, the state should be able to keep all $30 million of it. If it's some sort of, we ask for the money, it's a refund, you know, those sorts of things, then because the federal government, you know, pays for half of this, then we should be turning half of that back to the feds. And that was why I said, I understand that while the state, I thought the state had a reasonable position because it came as a donation, that it was, and we should be able to keep all 30 million of it. You know, understanding that that was not some clear-cut decision, I told CMS about it, you know, and, you know, was just trying to be very transparent with them that we'd received this, this is how it came to us, this is how we're characterizing it. Happy to discuss them if they thought otherwise. So I'm concerned that there was another part of your question. Oh, you asked about Karen Peet. She is not here. She's no longer working in that part of the department. She's working, and can I say, she's a 25-year employee of the department and now doing a good job working our continuing care area. But she's not here. You know, she, as I read those deposition pages, and I didn't see them until last week either, you know, I think she said she didn't recall saying that. So that's my recollection of Mr. Feinwach's exhibits. But, you know, I wasn't in the department then, neither was Mr. Leitz. So I just don't think we're in a position to comment on that one way or the other.
Representative McDonald?
Yes. My understanding that UCare is a public program. Is that correct?
Commissioner Jessen.
Mr. Chair, Representative McDonald, UCare is an HMO that does business, that specializes in doing business for public programs. They do both Medicare and Medicaid programs generally. But, there are people from UCare here who will know a lot more, and perhaps Ms. Bruner is better able to answer that question about UCare's business than I am.
Mr. Chair.
Representative McDonald?
Well, let me just get to the point
Go ahead.
then.
Yep.
I don't want to, beat around the bush. I think we have a very delicate situation where if there's $30 million that are overpaid, we must not be calling a donation. If it is a donation, fine, then correct me and I'll keep my mouth shut. But if it's an overpayment by the taxpayers, by no means should we pretend that it's a donation to the state of Minnesota when we paid our hard-earned tax monies for it to make sure that the population that we want to be treated should be treated and taken care of by our health care providers. So if I'm wrong, correct me, but it's no donation. It's giving back money that was overpaid. And if I'm wrong, correct me today. And then also, I still have not been answered, if it is a refund, should the feds clearly get half, like the email says?
Commissioner Jessen?
Mr. Chair, Representative McDonald, from my perspective, they characterized it as donation. When I looked at the contracts, I didn't see any reason under the contracts that they had to pay it back to us. So that was, but UCare would know more about why they characterized it that way, but I didn't see any legal obligation for them that they had to pay it back to us. If they had to pay it back to us, then clearly it would be, whether you call it a refund or, some other payment, then, the Fed should get half of that. And as I've said, I think I've tried to make clear, Representative McDonald, I'm the first to say that there is not some sort of crystal clear answer to this question about whether half of this should go back to the federal government or not. I think we have a reasonable position.
Representative McDonald, I think Ms. Worcester from UCare is here and could perhaps shed a little more light on this, too. Ms. Worcester, thank you, or welcome back again to the committee. If you want to kind of state your name for the record and who you represent.
I'm Gita Worcester, UCare's Senior Vice President of Public Affairs and Marketing. When you write things, sometimes you are not as clear as you wish you were. So we characterized what we were doing as a donation when we brought the concept to the commissioner in her office. And we believed that the decision for how the money could then be allocated, where the check should be sent, would be something determined by the Department of Human Services and, if appropriate, with the Centers for Medicare and Medicaid. I do want to clarify the use of our word overpayment. As I said, we talked through several different reasons that there was additional money at the end of the day in our bottom line. And we looked at all products together in state public programs that didn't have a Medicare connection and determined that we had additional money at the end of the day in 2010. So probably the word overpayment isn't very artful in how we were using it here, and I realize it's being used in this conversation as though we were being very specific with it, and we were not. We didn't have losses as a result of the fact that general assistance was closed down, and that was what we were trying to get across in the letter.
Very good. Representative Lane.
Thank you, Mr. Chair. Well, indulge me here. I have a few things. First of all, I want to say that I think everybody up there has agreed that it's no problem to have an independent third-party audit. I do have a bill, House File 2241, now introduced to suggest that every single year that they do a contract, January 1st, that part of the contract is that they agree to an independent, totally independent, third-party audit of that year at the end of the year, or the end of the contract. And it's very strict in sense of what that means as far as independent, because we want it truly independent. So if we do have agreement on that with all the entities, as has been said, I even heard the words, so it's paraphrased as bring it on. And I do believe that the administration is in favor of that kind of approach too, so let's do it. Let's get this simply, we need the data. we want it to be independent, here's one of the things we can do right away. Just get that into next year's contract. But so the questions or the comments I have now would relate to the fact that we don't always know the data, and I would hope that some of this would come out of an independent third-party audit. I will comment first on the reserves, because I did, when I first came to the legislature, that's one of the first things I did, is address what I thought was something that needed to be addressed, a cap on the reserves. We had taken that off in 2004, and they had gone up and up and up and up. And so I thought, let's be reasonable here. Let's put, I learned all about risk-based capital, RBC rates, to put it on, and I came up with something, and I presented it, and the person from the Department of Commerce said, oh, no, we don't want any cap at all. We want the reserves to be just as high as they can go, because the more the better. And that was the answer from Commerce. So, but that's not really the case here, because for one thing, they don't need to be. The risk-based capital actually is a formula that builds in the actual risk in that particular entity and sets a bottom line, and then a percentage above that is to what would be very, very comfortable, considering the exact risk of that entity, plus the times, plus everything that you can imagine, into the risk-based capital amount. So by setting it up at a few hundred risk-based capital, right now I would suggest 400 risk-based capital, we would know that, first of all, there wouldn't be a problem with risk, and second of all, we know that, in fact, a good percentage of the amount that the the HMOs have is not any risk at all. They're just simply third-party administrators to the money we give them, and then they spend them. So there's not the risk, as somebody said here, unless the state goes bankrupt. But just looking at that, let's just assume for a moment that we did address it all as a 400% risk-based capital. My understanding is that according to the numbers that we have now for the reserves that are out there, we have, if we take everybody 400% risk-based capital, we would have $800 million excess. $800 million excess over and above the 400% risk-based capital. To me, that is an example of how we are not being cost-effective in the taxpayers' money given to these programs, given to these plans to do these programs. It's just something else that needs to be looked at. I will leave that at that and go to my next subject, which is provider payments. We hear constantly about providers being uncomfortable with the amount of money that they are getting to do the jobs that they need to do, the actual payments to the doctors and providers. Not only do they negotiate with the health plans, the HMOs, the health plans negotiate with them to bring down costs, but also we as a legislature reduce their rates. And I have the House Research for Medical Assistance here. It's just put out October 2011. And here's list after list of payments for basic care services reduced by 1.5% for fiscal year 10 and 11. 4.5% here. Physicians and professional services, 3%. Outpatient hospital facility, 5%. On and on and on. We, as a legislature, reduce the rates that the providers get. So they're getting reduced by their negotiation through the plans. They're getting reduced by the legislature. So the providers that actually are the ones that are doing the job are getting cut. And I think that if we graphed how much the providers get, that graph would be pretty flat. But the amount that we are actually putting into the health plans seems to go like this, seems to go on an upward flow. And I just need to ask about that, I guess, it can't purely be enrollment, because one of the things we do with health plans is cut people off. We say, okay, we're not going to provide to people who have a certain level of income. We raise their already low level of income that we allow and say, well, we'll allow even less income to them. So we cut people off these programs. I don't know. So why, and this is an ongoing thing over many years, that the amount we put in goes up, and yet the amount that comes out the other end to the providers, which is where the money should be going, like we say 85% of the money we give to a school district goes into staff, it goes into teachers, because that's what they do, that's what it's about. And the money that goes into this goes into providing for health care services for people. That's what it's about. So why is what's coming out the other end fairly flat and what's going in keeps rising? I just throw that out there as a question, then I would have a comment after that.
Mr. Barsh.
Mr. Chairman, Representative Lane, I'll address your second question first and then try to address your first question second. In terms of the increased payments to the HMOs and then the following outflow of payments to providers, if you track the aggregate money to the HMOs and the aggregate money that's paid out to providers, they increase at the same slope. What stays constant down in terms of doesn't increase is the specific rate for each service, and I think that was similar to Representative Gruenhagen's comment earlier. So the state, through the Medicaid fee schedule, which is what they base the contract with the HMOs on, may only pay 25 cents per specific service. That has stayed constant over time. But over time, we have provided more and more of those services to providers, so the amount they receive in revenue is more than 25 cents. It grows at the same level of increase that we get as payments overall. The second part of your question, which was on reserves, first I want to disagree with some of the statements that Mr. Feinwalk stated earlier in terms of the health plans are not at risk. There are years in which our overall losses for state, we have losses for our state public programs. That includes Medicaid, Minnesota Care, and previously General Assistance Medical Care. We are at risk in those years. We do not get made whole. So we do carry the risk when we sign those contracts with the state. Secondly, you mentioned the appropriateness of reserves around 400%. I'm not sure what that is in terms of months of reserves, but that's about a month and a half, I think. The state used to require Blue Cross to carry at least 2 months in reserves. I can't imagine why we would start setting a cap on reserves that was below what we used to consider a minimum. Again, those dollars are there to protect the members that we insure so that whatever happens, increased claims costs, not receiving payment from one entity or another, that there is money in the bank to pay the claims. And the two states I know of that have put a higher level on risk-based capital, I believe one's at 1,000, I believe the other's at about 800% of RBC. It's not that we're opposed to having a conversation about what might be an appropriate limit for reserves. I think we've had that conversation in the past, we have it again. But it needs to be based on what is an appropriate risk for an insurer to carry and what's the appropriate amount of reserves for them to hold in order to protect that risk.
Representative Lane.
Mr. Chair, first of all, I would disagree that going back to the monthly rates makes any sense because the risk-based that's just simply a number. We spent this much, therefore we have to have a couple months worth there. The risk-based capital builds in the risk. Monthly is just a number. It doesn't have anything to do with the risk whatsoever. That's why it's there. The risk-based capital is actually a number that builds in the actual risk, not just a number that we happened to spend before. It doesn't mean anything about risk. So I would disagree with you on that. And you say that you are at risk to spend the money because things can go down. But you can it's sort of like my checkbook. I may have less coming in this year, so I have to make sure that there's something in the checkbook to cover this week or this month. I have to have something in the checkbook to cover it. But I know that when the check comes again, it's going to take care of that. And you will be made whole the following year because part of your negotiations is to cover what you paid last year. So there isn't that kind of risk of, I'm speaking very simplistically. I understand you see you sitting up, but there is part of the formula that we used is what have you spent in the last 3 years? Has it been? Okay, let's go up from there. And when you say that the providers get the same amount for service, that's what their job is, doing that service, and they'll get the same amount for service year after year after year. Do they not have any inflation to cover? Does their paper not cost more? Do their salaries not cost more for their staff? Why do they get the exact same amount for service year after year after year?
Mr. Chairman, Representative Lane, the state has not increased the fee schedule for providers.
Okay.
In fact, as you stated earlier, you've reduced the payments to providers.
Okay, then I would lead to
Representative Blaine.
Thank you, Mr. Chair. My last comments is just that if we have Commerce, Department of Health, and the Department of Human Services all involved in this, and everybody says, well, it's their job, this part is their job, and nobody's really clear on how it works, and there doesn't seem to be a lot of clarity around how we can straighten this out. Well, then let's do that. Let's talk about what the legislation would be to offer this proper departmental oversight. What would that be if who did what? What would that look like? Let's actually set up departmental oversight so that Commerce is responsible for thus and so. And it fits and segues very nicely into what the Department of Human Services is responsible for. And that segues very nicely into whatever the Department of Health is responsible for. And we have a system that actually works so that we don't have to wonder what's going on or why it's going on, why things change. We can actually have the oversight we need. We can actually have the numbers we need with ongoing independent third-party audits, and we can actually have the oversight that we need so that this health care field, which we say is costing us so much money, at least we know what the numbers are and who's responsible for what. That's my comment.
Okay, Representative Mack.
Thank you, Mr. Chair.
And I'll just mention real quick, I'm sorry, Representative Mack, we do have the Department of Commerce here, and they can answer questions from a commerce perspective about the reserve issue. We may, I don't mean to interrupt you, but we may in fact want to take that now in process since that was brought up. I think it's a very good line of questioning, Representative Lane, and something everybody probably wants to understand better. Our Commerce representatives, Julia Phillips is here from Commerce. Julie, do you want to help enlighten us about the reserve requirements for health plans?
Mr. Chair.
Yes,
I can just help frame the question since it was my question, and Mr. Reich is here too. So just good to drag him down wherever we can. No, he'll stand in the back and smile. The question was asked. We're talking about. Hello, back behind the chair there. We were talking about what kind of reserves are necessary, and the Commissioner of Human Services was suggesting that the Commerce Department would better answer that question. You missed the dialogue we had about 400%, 500%. Is it really money at risk, or is it just cost plus and there's a backstop so you don't really need a reserve? That's been discussed at some length through all this discussion. And so the question for whichever Commerce representative would be is, how do you figure what's enough? And I think HMOs serving state programs are different than HMOs serving commercial programs. And so can you comment about that difference? That's the whole question, I think. Is that?
If you can state your name for the record and your position, who you represent, that would be great. Thanks. Welcome to the committee.
Thank you. Mr. Chairman, representatives, my name is Julia Phillips. I'm the Life and Health Actuary for the Minnesota Department of Commerce. I have been responsible for the last 16 years for providing technical expertise in reviewing the solvency levels of all health insurers in the state. For the past 12 years, that has included HMOs under a contract with an interagency agreement with the Minnesota Department of Health. I also am responsible for reviewing the rates that are charged by health insurers and HMOs. And I believe the question, if I can just restate it, was what is an adequate level of free reserves or surplus for an HMO to have, and perhaps that the answer is different for an HMO that is providing services to public program enrollees as compared to an HMO that is only providing services in the commercial market. That's a fair statement?
Yes.
Okay.
It is, yep.
Okay. I was involved in developing the formula that when people say 400% or 500%, I was in the room for many hours as we developed the formula to calculate these numbers. It's something that applies to any health insurer. For a for-profit corporation, we call it surplus or capital and surplus. For a nonprofit, that's kind of an awkward thing to say, and so we call it free reserves. Those free reserves are the money that is there in case something bad happens, so that the entity, whether it be for-profit or not-for-profit, does not run out of money, and so that it can keep its promises to the enrollees. We generally consider 200% to be the minimum level. And in fact, the legislature passed a law describing what the Commerce Department should do if the risk-based capital ratio falls below 200%. And there's a whole list of things that we do to try to repair the situation. There is no standard for, in statute or in actuarial literature or in accounting literature, for the comfortable amount of free reserves. The Commerce Department in general, and I'm kind of standing in here for the Assistant Commissioner, which is an open position right now, who is really in charge of the solvency reviews. The Commerce Department does not ever want to see an HMO or a health insurer being unable to cover its obligations. And there are many things that can impact that ability. There are sudden jumps in utilization. I'm not old enough to remember the flu epidemic of 1918, but it put many life insurance companies out of business because they had surplus but not enough. Therefore, we're always in a situation where if we say 400% is plenty, there's some chance that the next year there would be a bird flu epidemic or some other consideration, and by law, the coverage is unlimited for HMOs. By law, they can't say, oh, your contract covers only the first $1 million and now you're on your own. By law, the HMOs have to pay the medical expenses of their enrollees without limit. Therefore, I think that you may have noticed that over the past few years and under more than one governor and under more than one Commerce Commissioner, we have not been forthcoming with a number that would represent the comfortable or adequate level of free reserves for HMOs or for insurance companies. And I think that part of the reason we have not been forthcoming is because of the very uncertainty and our sense that you can criticize them having too much. You can say, you know, they shouldn't have too much, and I totally agree with that. However, we don't really know how much is too much. And the drawbacks of having too much, which is, well, the money could be put to better use elsewhere, they could lower their rates, they could charge less, really are outweighed by the drawbacks of saying, oops, well, 400% looked like a lot of money last year, but suddenly it's not enough. So I will try not to go on. I'm going to try to be brief, but that's kind of the capsule information that I have.
Mr. Chair.
Representative Vabler.
Thank you, and I appreciate you coming over just to answer these questions. I have two questions. One is that, is it reasonable that the reserves, that the free reserve should grow every year for an HMO that serves in the state programs section? And is it reasonable that one would have 500%, one would have 800%, drawing money from the same source?
Thank you, Representative Abler and members of the committee. The percentage varies depending on the volume of business that the entity has. So the formula, you probably remember the corridors that we used to have. And the corridors were based on something like, I think, 2 to 4 months for the insurers and Blue Cross and 1 to 3 months of claims and expenses in the prior year. The risk-based capital is similar to that, only it's supposed to be more finely tuned. It looks at the volume of business. It looks at the riskiness of the investments. It looks at the type of business where if they have stop-loss coverage, there's a higher charge. If they have dental coverage, it's a lower charge because dental is less risky. So to some extent, the surplus should grow every year. I would say that if you're looking at the percentage numbers, that ideally it would not. Ideally, even if the entity itself is doubling in size or shrinking in size, if 500% of company action level is a good level, then it should be 500% all the time. However, there are a number of things that it's not like steering a car down the road. And sometimes you find yourself oversteering. And I worked for a health insurance company for 10 years. I come from the dark side. You know, I've recovered. But you know, when we would be losing money, as we lost a lot of money in 1987. And there was really an oversteering effect where the underwriters started getting very tough and they wouldn't accept a lot of applicants. And I was raising the rates. And, you know, the people who were administering claims were getting very tough because we all knew we were in trouble. And it kind of oversteered. And the next year, suddenly we were extremely profitable. And it was kind of like, you know, if you can tell me what the health care cost of a certain population is going to be in a year, you could get a job making a lot more money than I make because nobody really knows. So, you know, there's the ideal. If you look, and I have provided, you know, over the past few years, I have provided some historical RBC numbers, you know, to members of the State House. And if you look at those numbers, you can see that they do bounce around to a certain extent. And if you were to say to me, Julia, why did the Blue Cross free reserves go from a 600% RBC level to an 800% and then back down to a 500% or whatever, I would say, I don't know, and Blue Cross doesn't know either, because there are so many complex things that go into the mix. However, I will say that I certainly see the companies responding in their rate filings. We have a lot of companies across the United States that are filing their rates with the Center for Consumer Information and Insurance Oversight on healthcare.gov because they're raising their rates more than 10%. We haven't had that in Minnesota. Our rates are going up between 5 and 8% in general in the individual market in the past year. So, you know, to the extent that they have surplus, it does seem to be reflected in lower prices.
Thank you, Mr. Chair.
Mr. Feinwachs, briefly.
Mr. Chairman, members, briefly, first of all, to Julia, I heard you say there's a job open at the Commerce Department. Can I give you my contact information after the hearing? And secondly, I think the real issue here is this, and this is the question we need to ask. In the operation of these programs, is the state of Minnesota buying insurance from these organizations? Or, like an ERISA employer, are we holding our own risk and using these entities as disbursement agents? This is actually a threshold question, and addressing this would be useful in terms of framing this debate.
Ms. Phillips, do you have any response on that?
As far as the public programs, I would really have to defer to Commissioner Jessen, Mr. Chairman, and to Mr. Leitz.
Commissioner Jessen? I do think this is an important question. It's, you know, this has been the elephant in the middle of the room for, like I said, all the years I've been in the legislature, and I think it's worth trying to get at if we can a little bit, without putting anybody unduly on the spot.
Mr. Chair, I'd be happy to briefly address this, and I would also like to ask Assistant Commissioner Leitz to weigh in as well. I think I said in my opening remarks that one of the things that concerned me when I came into this job was the way we did our pricing for the health plans, that we were basically looking back 3 years and then making adjustments for medical inflation. And that's why I thought we should change that model, because while I understand that the plans are assuming some risk from year to year, I didn't think that, you know, there was a lot of risk, and I also just didn't think that provided incentives for doing things better, for changing, for lowering costs. So that's why we've been making a number of the changes to our purchasing process that we can. We have talked about, do we really just want to change that further? Those are some discussions. And at this point, I'll ask Assistant Commissioner Leitz to weigh in.
Mr. Leitz.
Mr. Chair and members, I think as Commissioner Jessen said, I think that's very much the nature of why we're doing some of the changes that we're doing around competitive bidding, because I do think that there was some concern when we stepped back, looked at the way that we historically set rates, which was really to look at history plus trend. It did not provide a lot of incentive to contain costs within that model or to reward innovation within that model. And so when you move from that sort of a more administered rate setting process to one that is more price competitive in a market, you really do change the dynamic of how those rates are set, because now it's a function of the entities themselves providing what they will take to serve populations, as opposed to us administratively doing that work. So I do think that there's sort of a question. I think it becomes, Mr. Chair, a question moving forward. Really, has the process that we've put in place really changed the dynamic of how risk is or is not taken? And I would argue that we have sort of fundamentally really changed some of that dynamic moving forward.
Commissioner Jessen.
Thank you, Mr. Chair. If I can just add on to Commissioner Light's. I do think that one of the things we're looking at, going back to where I talked about creating a third way, not just managed care contracting as we've done in the past, not just fee-for-service. One of the things that we do want to do to incentivize change is get, providers, and maybe providers then work with the health plans to take on more risk, upside and downside risk, gain sharing, to where we give them more flexibility so that they can, so they're not just, paying just for the test, and the incentives aren't towards overutilization. We hold them accountable for quality outcomes. But, and to do that, to change the incentives, we need them to take on more risk. So I think that is clearly the direction we're heading. Competitive bidding was a good first step, I think.
Very good. Good conversation around that. I really appreciate the additional information and appreciate you coming over, Ms. Phillips. Representative Murphy is next, and then I've got Representative Mack and Representative Loeffler. Representative Murphy.
Thank you, Mr. Chair, and to Representative Mack for letting me budge in, because I did have a question and follow-up to this line of questioning. And it is either for Ms. Phillips or for Commissioner Jessen or Assistant Commissioner Lights. And I want to go back to your hypothetical about the bird flu and free reserves and risk. And so if, hypothetically, a health plan had, a population that really exceeded, their expectations in terms of utilization, and they blew through their reserves, what would happen to the enrollees? And would the state still have an obligation to provide care? So if the state still has an obligation to provide care, doesn't the state hold the ultimate risk in this situation?
Ms. Phillips.
Representative Mercy, Chairman. For a commercial population, I would answer that because we have it in Chapter 62D, what would happen to the HMO enrollment. I am not completely familiar with what would happen in the hypothetical area where the public programs, because I'm not sure to what extent they fall under the normal enrollment. So I guess I will kick the question over to Assistant Commissioner Lights. Looks like he's on the spot here.
Mr. Chair, Representative Murphy, and I do think that's a useful distinction that that Julia drew between sort of the commercial part of the world where the state does not necessarily have an obligation to do that, and public programs where we do have to cover the costs. And really, I'm going to talk just real briefly about sort of the way then that the federal government has sort of thought about this issue. And when many states, and many states do contract with health plans to do administration of the Medicaid program, the rates that are paid by the state to those entities have to be sufficient to cover the expected costs of the program. And that's why it's so important that those rates be sufficient to do that. I think on the other hand, what we saw coming in was that the rates were certainly sufficient, and in many cases probably more than sufficient to cover that because of the margins that were on the program. So I think it's really a balance between those two things, which is ensuring that we are able to pay rates that are sufficient to cover the costs of the services that are being delivered to the population without paying so much that there is excess margin being gained at taxpayer expense. And that's really the balance, I think, that we always try to strike in these things.
And Mr. Chair.
Representative Murphy.
Yeah, thanks, Mr. Chair and Assistant Commissioner Lights. I understand that balance, and I think that's the right balance. But I think it's important for us to understand the final obligation, who holds the final risk with regard to those people that are enrolled in the public programs. And as we talk about the financing, it's important to understand who holds that final risk. And I think that point needs to be really underscored in this discussion. Thank you.
I think that's a very good point. I just want to lobby in here briefly to say this is at such the heart of the issue for so much of this stuff. We are, in a sense, alleviating some of the risk that we hold on behalf of taxpayers by using the health plan's reserves. And if we decide we don't want the health plans to have reserves for public programs, then the taxpayers will bear that completely. And so that's a policy discussion. Should the health plans bear part of the risk through their reserves, or should they bear all of it, or should the taxpayers bear all of it? So, very good question. Representative Mack, and then Representative Loeffler.
Thank you, Mr. Chair. I have two questions. The first one is back to the issue of the $30 million that was donated or paid back from UCare. And my question, I guess, is probably for the department. If nothing, I'm just trying to get to, because we've heard a little bit of back and forth on the language that was used in the letter and what was stated, but I'm just trying to understand if there was, when GAMC was done away with and that change was made, was there any change made at the department level, particularly after this letter was sent, and if anything was brought to the attention of the overpayment or the excess payment that was there after the change with GAMC? Has the department done anything to look at that issue? Has that been addressed, and if not, why?
Commissioner Jessen.
Mr. Chair, Representative, I think you have to think about this a little bit chronologically. So GAMC ended, I think, in the spring of 2010, my recollection. You all were here, and I wasn't in this seat. And UCare made their donation on March 14th, I believe, 2011. And honestly, I didn't see the letter from Nancy Feldman that's been much discussed here until recently. But so I think your question really is, and you can certainly correct me if I'm wrong, look, once this issue about kind of the rates, was issued, were we inappropriately using our MA payments to kind of subsidize the health plans because they were taking a hit on GAMC, and GAMC goes away. What did the department do? It's a little harder for me and for Commissioner Lights because we weren't there then. I mean, I think that the question I can answer is when I became aware of this allegation of wrongdoing, kind of what did we do? And I think that one, after GAMC went away, we knew, and after we were doing competitive bidding, we knew we weren't paying, doing rate setting in this way anymore. So if there were concerns, we had changed that. I think there's also a question about, is there a duty to go back and look at what was done in the past if questions have been raised and say, should we investigate that? And that's where I was trying to say earlier, at the same time I learned of these concerns, I also learned that there was a federal investigation into this matter, which we are cooperating with. And I thought that was the best way, cooperating with that investigation, to look at this issue, which, I see, as I said, looking at chronologically, as different than the UCare donation. And as I said before that, from my perspective, they came in, they said it was a donation, and when I went, sat down, and as Commissioner Lights knows, looked through all of those 2010 contracts, because I wanted to know if there were things, that were done in 2010 that were effective in 2011, because I wanted to know if there were changes that we could make. But I didn't see anything in those contracts that required UCare to give us that money back. And as whereas there's something that should have been investigated that, morally caused them to do this, that's something that, perhaps this investigation will reveal. But that was before our time.
Mr. Chair.
Representative Mack.
Brief follow-up to that question. So if I understand correctly, you had said that some of the issues with rates that had possibly led to this excess, did I understand you correctly that some of that had been dealt with already? Some of those issues have been addressed, and if I am understanding you correctly, then those would be in effect from here on out. So it could be safe to assume that this year, UCare and the other plans, but we know for sure UCare would not necessarily be seeing that same excess over and above what they need to meet their obligations.
Commissioner Jessen.
Mr. Chair, Representative Mack, you're correct. What my understanding of the concerns raised is that there was this interplay between, which some say was inappropriate, between the GAMC rates and the MA rates. Because GAMC went away, that's one reason that we're not, that's obviously not an issue today. But I think even more fundamentally, what we did when we came in, and recognizing, as I think Commissioner Lights and I both tried to say, that we thought we were leaving money on the table. So we really did the competitive bidding exercise to try and to clear the decks and kind of press reset on the rate setting process. To introduce some risk and competition into this. And we took not only, while we did that in the metro area, we took what we learned from those rates and applied a rate cut in greater Minnesota, albeit not as large a one, as a result of that too. So I think for a number of reasons, it's not a question about what we're doing today. I think these questions were raised about what happened in the past, and as I said, I think those are being looked at.
And Mr. Chair?
Representative Mack.
Could I just ask if Mr. Feinwachs, in your research and you're looking at this, would you agree with what the Commissioner is saying, that some of the issues that maybe led to the $30 million in excess, that they have been addressed, that we're moving forward in a direction where that wouldn't take place again, or where the money is a little bit more tightly held, whether it's by the department? I guess I'm just wondering if you have a response.
I believe,
Mr. Feinwachs.
Mr. Chairman, I believe that the Commissioner and her staff are in fact beginning to look into these questions, and I commend her and them for that. I think the inquiry is long overdue, and I think we've got quite a ways to go, because one of the issues apparently that's been raised here is there's nothing in the contract that required anybody to give back any money. But there may be something in the federal law that requires them to give back the money, and those are the issues, I assume, that will be explored.
Representative Mack.
Thank you, Mr. Chair, and thank you for that. And then my other question on a separate issue, I'm just, lots of questions, and this is all very complex. And at the end of Mr. Feinwach's presentation, I'm just asking this because he provided this, and I didn't necessarily see material from anyone else, but he has kind of 3 bullet points here at the end. I don't know if everyone's had a chance to see that. Independent third-party audits, encounter data claims and payment data, and a prohibition on the state's actuary serving as a consultant to the state's health plan vendors. My question is, I guess, to the plans and to the department, and this might be overly simplified, and if it is, I apologize, but I guess I'm just wondering, what are your response to these 3 asks of, they just happen to be Mr. Feinwachs, but I'm just curious, what are your issues with these? What are your concerns? Why do they not work? Why do they work? And then if Mr. Feinwachs could respond to theirs. I guess this question is coming from, I've had lots of conversations round and round with various people, and this is a great opportunity where you're all right here and it's not bouncing back and forth. So I feel that it would be helpful to just kind of get some straightforward responses to some of these things.
We'll start with Commissioner Jessen, then maybe you can just raise your hand. No, we'll go across the table here. Okay, Commissioner Jessen.
Mr. Chair, Representative Mack, we strongly support having independent third-party audits. We also, the concept of having kind of a prohibition on the state's actuary serving as a consultant to the state health plan vendors, that is, we think that's important. I mean, we've already included, basically, I think that prohibition in our contracts as a matter of contract. To have it in statute, we think is appropriate. I think there's some, as with everything, a few details you have to work out and how do you define it all, but I think that's important. And I think I was trying to say earlier that I think it really is important to have quick access to this encounter and price data. We've started collecting that last year. We need to make sure it's both usable and that it's accurate so that we can make decisions going forward on usable, accurate data so that we know more how our dollars are being spent. I think we've got to start on that. That's something that we endorse.
Mr. Barsh?
Mr. Chairman and Representative Mack. On the first bullet on the issue of independent third-party audits, I think I'll rephrase what Ms. Bruner said earlier, which is, we're audited by multiple entities and agencies now. We'd welcome a different independent third-party audit. Obviously, someone's version of how that looks in a bill is different than someone else's version of how that looks in a bill, so I don't want to endorse any piece of legislation at this time. But the idea of an independent third-party audit is something we have supported. I think we stated that last year when this committee heard this. In terms of the encounter and claims payment data, we've been submitting the encounter data to the department for years, as Commissioner Jessen just stated, beginning with the contract that was signed at the end of 2010. That includes specific price information. We do that in the manner and form that's specified by the department. So if they are working to change that in a way that helps them validate that data, we'll certainly comply and are happy to do so. And then as she also stated, the prohibition on the state's actuary serving as a consultant to the state's health plan vendors, I think as the commission just stated, that's a part of the contract right now. We don't see any issue with putting that in place as a way to keep any conflict of interest from occurring.
Mr. Feinwachs.
Mr. Chairman, members, obviously the definition of independent and the independent third-party audit is absolutely key, and if they are indeed independent, they would be a wonderful thing. We live in an age of computers and data, and there is no reason that the state should not be able to track encounter and payment data for its programs and its tax monies right now. Most of you have on your smartphones enough computational power to do almost the task that needs to be done, and there's no excuse for us not doing it, and I welcome the responses that say we should do this. And in terms of memorializing in statute the prohibition against the state's actuary consulting, I think it's an excellent idea. It's long overdue, and I would prefer to have it in statute because, of course, contractual provisions can be waived.
Representative Mack, have I got a bill for you?
I was going to say, Mr.
I
Chair.
think Representative Lane does too, just to be bipartisan here.
Well, from those, I appreciate the responses, and it sure doesn't sound like we're all that far off from where we all think we want to go. It doesn't sound like what Mr. Feinwachs, at least the way it's outlined here. Mr. Barsh, you said obviously the details are key. But I guess that's just what I'm trying to get at. In individual conversations, it seems like one side says they don't provide it, the other side says, yes, we do provide it, and trying to really understand what actually is being provided, what does the state have, what don't we have. And from all of your responses, it sure seems like, we're a lot closer than we are far apart, but still trying to figure out where this is all falling apart. So thanks.
Representative Loeffler.
Thank you, Mr. Chair, and thank you to everyone for paying attention to what I think is an important issue. And I want to commend the Commissioner Jessen and Assistant Commissioner Leitz for taking on this issue and trying some new approaches. I think we're kind of overdue on looking at this issue, not that a lot of people around this table and elsewhere haven't tried. And I think we're making progress. But once again, we're still focusing on managed finances rather than managed care, and that's my biggest concern. Even moving forward, it's a lot about competitive bidding, which was based more about bids than past performance, even though every single one of the bidders has had extensive long-term performance data, not as robust as we'd like. But we need to move forward, and I think because the whole system to me has to be focused on managed care for better outcomes, because the risk isn't just financial. The risk is to the finance budget for health and human services. When kids aren't healthy, they don't learn, and that adds to our education budget. When someone's mental health issues aren't addressed as effectively and as quickly as they need to be, we don't get them back to work. And self-sufficiency. And the cost to our criminal justice system when we don't deal effectively with chemical dependency are very, very clear. And so the risks of our system are more than just financial related to this contract. They're related to absolutely everything we do and have impacts beyond the scope of this committee. What I would like to hear a little bit more about is a new area of the future, and we did this for finance reasons, not necessarily because anyone's proven that managed care entities are the best and best able to step up to serve people with serious disabilities. It was really more about how to save money in the next budget going forward, and I'd like to hear how we're going to balance the financial risk and the contracting for serving people with disabilities. Because right now, we as a state, under the fee-for-service system, are taking that risk. And even though we know there are some people who I've heard as much as $1 million a month of the cost of their medical care, it's shared around the whole state. And we're going to divide that sharing of risk into individual contracts with up to 5 different health plans in 5 or 6 or 8 different regions of the state. And so we could have dividing that risk into 35 contracts. And I'm afraid that when we divvy up that risk and assure everyone against getting that really catastrophic case, we're going to once again be back in here in a few years talking about how much reserves were built up to deal with this population. And without effective quality of care measures to see whether or not we're really buying what people need, because particularly for this population, we use Medicaid to buy social services, independent living skills, things that are not going to meet the traditional health plan definition of medical necessity. And every time we've brought a new group into managed care, we've had big problems with that definition of medical necessity and what's necessary. So if we could spend just a little bit of time saying how these issues are being addressed in that tough burden of new responsibility that we've given you, and I'd be interested in both the department's perspective as well as that of the health plans.
Commissioner Jessen, you want to start it off, or?
I'll defer to Assistant Commissioner Lights.
Mr. Lights, okay.
Mr. Chair and Representative Loeffler, I think you've hit on a series of very good questions, and let me just step back and give the committee a little bit of a sort of a process update on where we're at on things. And as you know, last year there was a real brief one, Mr. Chair. Don't worry, I'm not going to go on at great length here. We passed a law that brought individuals into managed care, both adults and children, in an opt-out perspective, and we're processing through that in a phased fashion, so that we're bringing on new groups monthly into this year. And the children, which have not been in SNBC products, special needs basic care products before, will sort of be the last group to transition in, because they're the group that both we have the least amount of experience with and the plans have the least amount of experience with. And so we're working through that process. I think the way that we've tried to do this is a really open process of bringing in the disabled advocates, bringing in the disabled community, working with the plans and providers to try to make this transition as smooth as possible for individuals. You're right. There are some issues around unpredictability of risk with disabled populations that are different than a families and children populations. One of the reasons traditionally that has been in the fee-for-service world. But we have learned some things through the development of the SNBC product over the past several years. This is obviously a much bigger expansion, and so as we go about the rate-setting process for this, and as we go about contracting with the plans to do this, I think reporting and monitoring is going to be the key piece of knowing where we're at, both from a financial perspective as well as any transitional concerns that might be there. You also hit another very important issue, which is the quality of care measures, and you're absolutely right that some of the existing measures that we would traditionally use for a non-disabled population don't necessarily translate as well to a disabled population. And that's something that I think collectively as a community, that's something we need to work on to make sure that we get the right measures in place. Again, I think folks in Minnesota's disabled community have been really national leaders on helping to think about actual functional status measures that we can start to put in place. But those aren't there quite yet. And so that is another piece that I think we're going to have to closely monitor moving forward on this. So those are some sort of thoughts on kind of how that process is rolling out and the issues that we're considering. The final one that I'll mention really relates to how do we properly risk adjust for these populations as well, because as you've identified, there is larger levels of disparity in costs on a month-to-month basis as well as risk on a month-to-month basis for folks. And so that's something that we also need to continue to work on. Again, we're trying to do this in a phased approach so that we're addressing these issues as we move forward while trying to be careful not to overwhelm the system at once, but also trying to sort of know what those issues are so that we can prospectively look at them.
Mr. Barge?
Mr. Chairman and Representative Loeffler, I think both you and Assistant Commissioner Lights raised all the relevant questions, and one of the reasons why, as he mentioned, there's a number of people working together to try and work through this. It is a new process, but again, measuring outcomes and also how the program works from a financial standpoint are important as you all evaluate whether or not it's something to continue moving forward. And we're very happy to work with the state and stakeholders as we roll this process out to make sure that it's in the best interest of everyone.
Representative Barrett. Representative Loeffler, real quickly.
Well, I was just going to follow up and say I'd be interested in following up further about some new approaches to sharing that risk, because I don't want us to pay for that risk more than we need to. And it's a population we've served within the state budget for a long period of time. So I think maybe that there might be some new answers there.
Representative Barrett.
Thank you, Mr. Chair. A few questions here. I'll try to make them brief, but the first one is for Commissioner Jessen. You had mentioned earlier a federal investigation going on. You also mentioned, and it's obvious that some things can be discussed, or can't be discussed, I should say, because it's an ongoing investigation. But certainly there are things that can be discussed, and certainly us being the deliberative body of the legislature responsible for health and human services, both from a policy and a finance perspective, we would need to know if there's any risk going forward from the state budget or otherwise. So the question I have for you is, at what point were you aware that there is a federal investigation? Is there anything in writing you could share with us? And then which branch of the federal government is investigating?
Commissioner Jessen.
Mr. Chair, Representative Barrett, with regard to when I became aware of this last summer, when we were approached to ask for our cooperation in the investigation, to give documents and other information, that's when I became aware of it. I was asked not to say anything to anyone. Very, very few people, even within the department, knew about this. And I specifically, as I think I mentioned, but I'm not sure, said earlier, last Friday, I called and just asked for specific information, specifically to be able to tell you that there was an ongoing investigation by federal authorities into some of the allegations which have been discussed here. And that I was given permission to say that, and only that. So and I asked specifically if I could say who in the federal government was doing the investigation, and I was told I could only say that it were federal authorities were conducting this investigation. And I unfortunately really, as far as your question about some of the scope of this, I was just told not to say anything, but I would also say I'm not sure I even have the answers to most of those questions. The federal government's doing the investigation, we're cooperating. I can surmise some things based on what they've asked us, but I don't know the scope of their investigation or what they're looking at or frankly, how serious it is.
And Representative Barrett, I'm anticipating that at some point, and I know Senator Nenow is here as well, that we would want to get a report back from the federal government on their findings. I'm sure they'd either issue those anyway, or we would want to hear them. And I would make a commitment on behalf of one committee, at least in the legislature, that we would request that, so we'd have those answers. Representative Barrett.
Sure. Thank you, Mr. Chair. I'll move on. I would like to maybe know more about that. I think there is more that could be shared. If there's anything in writing that you could actually transfer over to our body, I think that would be good. I think we do have a need to know in this area. We are certainly one of three branches of the state government, and I know there are certain times when the feds can tell us what to do and other times they can suggest. And I'd like to understand more about whether they're suggesting or telling, but that maybe is a conversation for another day. Question, Mr. Barsh, about the UCare return of $30 million voluntary contribution. Do you know what the reserves were of which that $30 million were based upon?
Mr. Chairman, Representative Barrett, I don't represent UCare. I think you'd have to ask them that question.
Okay.
Let's see if anybody's still here from UCare. Yeah. Is there another question you can ask? Well, I think there's going to need.
Yeah, they're kind of built on each other, actually.
Right. Why don't I do this? I'm going to hold that question for a moment, Representative Barrett. I want to mention we've got Representative Franson, Representative McElpatrick, Representative Benson, Representative Gruenhagen, Representative Huntley, Senator Nenow, and then perhaps some closing comments to get done in 15 minutes. and then we'll have to close things off.
Mr. Chair, if I could just I do have a couple other questions. I'll try to get to those first. I don't want to lose the floor here.
Representative Barrett, go ahead.
Thank you. Mr. Barsh, can you describe the nature of the conversations you've had with DHS about voluntary contributions being made back to the state? What's the nature of them? How often have they happened? Who has been involved in those conversations?
Mr. Barsh.
Mr. Chairman and Representative Barrett, after UCARE announced their decision last year, I think the governor indicated that they would be contacting all of the HMOs about that. We got a call from the Department of Human Services. We declined their request because their situation was different than UCARE's.
Representative Barrett.
Okay. The next question then is for Commissioner Jessen. Can you tell us what your conversations have been with the HMOs regarding this issue? I know back in March of 2011, there was a communication out of the governor's office that talked about 4 different things that you were on, and certainly some of these you wanted to do very quickly. One is competitive bidding and managed care. Another is an executive order on disclosure and accountability. The third one being a return for taxpayers. And let me just read you this, and maybe you could reply and see if you could let us know what's been done in that area. Following a voluntary contribution of $30 million by UCARE from its excess reserves, the administration will continue to call upon the state's current contracted providers to return its own excess reserves and profits, with the industry's most recent numbers to be disclosed as required on April 1st. So the communication happened on March 23rd. The disclosure should have happened on April 1st. It's February 14. If you could let us know where we're at with that and how much money we could expect to get back.
Commissioner Jessen.
Mr. Chair, Representative Barrett, after that communication went out, I thank you for reminding me of it, I did actually call up and set up meetings with each of the other, I think, at least the 3 major health plans. I held meetings with them. I talked with them. I asked them. And they, as Mr. Barsh said, all told me no. It was after that, and I was trying to think about next steps, that I thought, well, if they're not going to take the step of making a donation to the state, then what can we do under the 2011 current contracts? I looked at that. I didn't see a lot of options. And that's when I thought of the idea of, well, let's see if we can get them to agree, at least for this contract, to a cap on profits. And so I then approached each of the plans about that, and we ultimately got that agreement, which, as I said, I do want to express appreciation to the plans for agreeing to that.
Representative Barrett, one follow-up, and then, sure. Okay, good.
So then I have in front of me an email, or a letter actually from UCARE regarding their $30 million contribution. And they say the $30 million represents what we consider to be excess 2010 operating margin for state public programs, plural. The margin was due to several factors: sluggish economy and high unemployment that increased the eligibility and enrollment, but the utilization of health care was significantly lower. So the question I probably have for Commissioner Jessen is, wouldn't those same criteria apply to all of the HMOs, so that there should be excess operating margins due to economic factors overall?
Commissioner Jessen.
Mr. Chair, Representative, I certainly made that argument when I met with them, you can be sure, and called upon them in their civic duty to follow UCARE's lead, and but they said no, so I went to my second step.
Thank you.
Thank you, Representative Barrett. Representative Franzen.
Thank you, Mr. Chair. I have about 4 questions, and I hope they move fast. And if they've been covered, just let me know. And
can we maybe keep it down to a couple? We're literally 10 minutes left with 5 other people who need to.
All right. I believe that this question has been asked numerous times over the years, and I did not hear it today. But who sets and certifies the Medicaid rate in the state of Minnesota to the federal government?
Mr. Lights.
Mr. Chair, Representative Franzen, the rates that are set for paid for capitation are set by the Department of Human Services. Those rates are certified as being actuarially sound by our contract actuary, and then the CMS has to approve those rates as part of the process.
Representative Franzen.
Okay, then moving on here, and to Commissioner Jensen here, you had mentioned a profit of, you're going to cap the profit at 1% that the health plans had voluntarily, or said that they would do, correct?
Commissioner Jessen.
Yes.
Okay.
Representative Franzen.
Mr. Chair, and Commissioner Jensen, could you explain, in your opinion, what is profit and who defined it, and how was the profit calibrated, and how does the public truly know that profit was capped?
Commissioner Jessen.
Mr. Chair, Representative Franzen, we defined profit as operating margin, and one of the things we're going to do, I think Assistant Commissioner Lights discussed earlier, the audits that we're doing of the health plans. One of the things, in addition to looking at administrative costs, that we'll be very careful to look at is how is whether or not they are actually returning what is in excess of 1% of that operating margin. So that is one thing we will be very carefully looking at the department.
Okay, thank you.
Representative Franzen, thank you. Next, Representative McElfather.
Thank you, Mr. Chair. And thank you to all of you for answering all of our questions. I have a couple of concerns, two questions, and I'll take it down to one. It seems like there was awareness over a considerable period of time about what I would term an excess in the normal reserves. And quite a period of time has gone by, and we're just looking at this now. And I'm wondering, I guess primarily for Commissioner Jessen, in recognizing that we had a substantial amount of money over what could be considered normal reserves, do you feel that there should have been a responsibility to bring that question to the legislature, just simply because this just seems a little out of norm?
Commissioner Jessen.
Mr. Chair, Representative, I've only been in this job 1 year and 1 month, and I think for myself, when I got here, I felt that the issue of reserves was very much being discussed in the legislature last year. I mean, I thought that was something that was very much a topic of discussion that I didn't need to raise or bring attention to. What I did, in my job was to try and negotiate tougher contracts so that we were not contributing as much to those reserves as we had in the past. But so just given my short period of time here, I think that's the only way I can respond. I can't speak for previous commissioners.
Representative McElfather.
Thank you.
Representative Benson, and then Representative Huntley.
Thank you, Mr. Chairman. This is for the Commissioner. We've been here about 3 hours, and I think we could probably boil down to most of our conversations have been around accountability and public trust. And you're a professor of law, and I just draw your attention to this one email, and it's been brought up again before, and it continues to evolve around, for me at least, this $30 million. Having unfortunately been involved in other investigations myself, I know that the probability of discovery would require that if you're trying to keep things secret, you wouldn't send emails. And I just want you to respond to it. And I thought we were going to handle this through phone calls. And I'm stating the obvious to many, but that seems odd that would be in an email unless it was in order to make sure that it wouldn't be brought up in discovery, that there was some question about the legality of not splitting the $30 million.
Commissioner Jessen.
Mr. Chair, Representative, I'm glad you asked that question, so I have a chance to address it. I wasn't trying to keep anything secret. I was the one who went to CMS and told them about this the next day after I sent that email. If you read the chain of emails, I was answering an email both about how to characterize things in the press release and also about giving a heads up to legislative leadership. And I had suggested when I talked with folks that they call the chairs of minority leads about this and talk with them and explain it. Now, that wasn't because I was trying to hide anything, and I think if you ask the chairs of this committee, they will tell you that I'm often someone who advocates actually talking with people rather than sending emails. We were actually kind of as early in the session, we were trying to establish working relationships, new working relationships, and I was pushing all of my staff to actually not just send emails, but to go over and talk with people. And that's what I meant by that.
Okay, Representative Huntley.
Oh, Mr. Chair and members, I've got some comments. One on the reserves, second on the so-called federal investigation, and then a suggestion where we might go. Like Ms. Phillips, I don't remember the 1917 flu epidemic.
No comment.
But I am aware of the 80s, and we had a whole bunch of HMOs in Minnesota that went bankrupt in the 80s. And that doesn't mean they just went out of business. That means the cost of that went on to the other healthcare providers. So it's not just a hypothetical case that these companies can go bankrupt. It's happened before, and we need some reserve to protect for that. On the federal investigation, my understanding is that somebody has filed a court case, and that HHS and the federal government must investigate, no matter the legitimacy of that or not. They have to investigate. That doesn't mean we've done anything wrong. And I will say that if it's related to the appropriate federal contributions that are usually made, if we don't get investigated a lot, it's because we're not doing our job. We need to maximize our federal contributions on all these programs. And, you know, we send $1.17 to Washington for every dollar we get back. And we need to try to get that up to 117. And I will say on there's all kinds of things, intergovernmental transfers. I mean, it used to be that actually the University of Minnesota would write a check to the state of Minnesota for several $1 million at 10 minutes to midnight. And at 10 minutes after midnight, the state would write them a check back, and the feds had to match it. And it was legal. And if we don't have our, you know, we've got a floor of people in the Elmer and Anderson building trying to figure out how to maximize our federal share. Unfortunately, there's entire buildings in Washington of their bureaucrats trying to prevent this.
We've got to care for that, Representative Huntley.
We need, if we get investigated once in a while, we ought to be. And if we're not pushing the edge, then we're not doing our job. The last thing I would say is in the 2008 Legislative Auditor's Report, which I have right here, he said, Minnesota should continue to rely significantly on managed care to serve enrollees in the state's publicly funded health care programs, but with enhanced efforts to contain medical and administrative spending. We passed many laws in 2008, 2009 to do what the legislative auditor thought we ought to do. And there was things passed last year that address these same issues, and I think that we ought to have the legislative auditor look at this. I mean, the legislative auditor's office, I think, is the one part of state government that everybody agrees may not like the results, but nobody questions whether they're correct or not. And I think that we ought to have the legislative auditor redo that whole study, see what we've done since 2008, and see if that has made any difference, and that what we could do in addition to get more information that we need.
Thank you, Representative Huntley. Senator Nino.
Thank you, Mr. Chair. Thank you, and thank you for holding this hearing. If I could get a page, I've got a handout for the members.
Okay. If you want to go ahead with your statement, because we're almost out of time.
Absolutely.
But,
I just wanted. This is just for the members' benefit. Yep. Earlier, Representative Huntley made a comment, and correct comment, actually, but I think that in the context of what I'm handing out is kind of indicative of some of the underlying problem or challenge or whatever word you want to use there with what we have in this particular circumstance. Representative Huntley, you mentioned the federal government certifies the rates, and they do, absolutely. And the implication there is that we've gone through the process here at the state level, and the feds have seen it and certified the rates, and everything should be fine. And maybe it is. But what you're getting, members, is a report from the GAO, General Accounting Office, to the United States Senate committees and United States House committees. And you can read this at your leisure. I know you guys live for this stuff in the House, right, these reports. But really the pertinent part is in the inside of the cover, or inside of the front page cover on the bottom. There's two paragraphs on the bottom of that page. And if you really read those, that will essentially set the context. I just want to read a couple of statements. This entire report is about rate setting for managed care. CMS regulations do not include standards for the type, amount, or age of the data used to set rates, and states are not required to report to CMS on the quality of the data. And down lower, it says that all of this, which places billions of federal and state dollars at risk for misspending. Basically what the GAO said is, yeah, they certified the rates, but the process and the underlying procedures and policies and the data are not necessarily reliable because of the way the system is set up. And I would just suggest to you, as you move forward on this topic, when we hear conversations and we hear testifiers that say, yes, we're audited, we have these reports, ask the question, do they mean anything? When we hear that the rates are certified by the feds, ask the question, does that mean anything? Because based on this report, it maybe doesn't. And we have to challenge that and ask, is the underlying data accessible, available, reliable? Are the procedures that we as a legislature set up really building us to come to a good outcome?
Thank you, Senator Nino. Real briefly, Representative Liebling, we're already over time.
Yes, thank you, Mr. Chair. Well, I just wanted to really express appreciation to the Commissioner and her staff. And, in 13 months, she's obviously done a whole lot to begin to tackle this very difficult issue. And I just want to express our appreciation for the work that she's done, and to everybody for sitting here and going through this today.
And I appreciate that, and in fact, I'll extend my appreciation to all of our testifiers and all the people who helped them with their testimony. I think this is a very important hearing, and I want to thank all the members for sticking around and asking good questions. Representative Abler, you get the last word.
Well, thanks, and I want to echo what Representative Liebling and Gottwald about that. Thank you for this. I think this was a very good hearing. We had a lot of respect, a lot of good data. More to come when the next bill comes up with whatever the product of this will be. Just an announcement for my members. We were going to meet at 4:30. It's Valentine's. Can you come to my office right now for about 6 minutes, and then you can go, and we'll not have the hour-long meeting. How's that? Thank you, Mr. Chair.
Members, we stand adjourned.